My name is John Vandenenker. I'm a pediatric clinical pharmacologist at the Children's Hospital in Washington, D.C. And today I'd like to discuss with you prescribing drugs in neonates, infants, children and adolescents. Before I start, I'd like to disclose that I have no conflicts to disclose. And I have to disclose that all neonates treated in the neonatal intensive care unit are exposed to unlicensed and/or off-label drug use, and as such I will discuss this kind of use. Always ways to go back in history when you have a chance, and this is a slide showing you historical drug development in children. It was called Cobb's baby's friend or Todd's teething cordial. It was against colic, diarrhea, cholera and teething, and it contained 8.5% alcohol and morphine. Clearly it worked very well, and what can be read on the lower part of the slide, it satisfies the baby, pleases the mother and gives rest to both. Very, very noble things to do, but hopefully we get some more evidence based in the coming years. These wonderful babies' friends led to a lot of mortality because children died of morphine intoxication. Then in 1937 the elixir of sulfanilamide was produced, a liquid form of it, using a solvent called diethylene glycol. And what you need to know is that diethylene glycol is antifreeze, something you put in your car in the winter to prevent it from freezing. It was administered to mostly children to treat streptococcal infections, and then existing laws didn't require any kind of pharmacological studies demonstrating that the drug was safe. Therefore 107 people died. Based on that misadventure in 1937, in 1938 the Food, Drug and Cosmetic Act was created. Extended control to cosmetics and therapeutic devices. It required new drugs to be demonstrated as safe before marketing. It provided standards and safe tolerances, and also it authorized factory inspections. Then several years later the Thalidomide Crisis in 1961 happened. The drug was hailed as a wonder drug for sleeplessness. It relieved also many morning sickness symptoms in pregnant women. At that moment it was unknown that thalidomide was crossing the placenta. It had catastrophic results. Peripheral neuritis, nerve disorder, birth defects like deafness, blindness, disfigurement, cleft palate, internal defects and phocomelia. And in this slide you can see clearly the children with phocomelia in the swimming pool, real major disfigurements of their extremities. Because of that misadventure in 1962, the Kefauver-Harris amendments were created. Drug manufacturers were required to prove drug effectiveness and safety to the FDA before marketing. Advertisements must show complete information on benefits and risks, and adverse effects must be reported to the FDA. Therefore, since 1962, thousands of drugs have been removed from the market because of these amendments. When you think about children, think about therapeutic orphans, because by an odd and unfortunate twist of fate, infants and children are becoming therapeutic or pharmaceutical orphans. However, many of the drugs released since 1962 carry an orphaning clause, for instance, not to be used in children, is not recommended for use in children and infants. Since then, few studies have been conducted in this age group. So these are the premature babies we're taking care of nowadays, born after 24 weeks, and we all know normal gestational age is between 37 and 42, so very young children. This is a child of only 500 grams, and we're taking care of these babies in intensive care. In addition, we also take care of full-term babies in intensive care, but when they have an issue like intestinal obstruction like this baby, or when they are severely asphyxiated during the delivery, or when they have other congenital malformations. So when you think about treating patients just in the neonatal intensive care, there's already a tenfold difference in just their weight. So when you're going to use medications for these children, you have to be very knowing what you're doing. And I think it's important to realize that of the fact that so many medications are used, we don't know that much about them yet. This slide shows you, in more than 70,000 patients, the rate per 1,000 discharges of the top 50 medications. The medication used in the neonatal intensive care unit. This is data provided by Pediatrics. Pediatrics owns half of the NICUs in the US, and it talks about more than 70,000 newborn babies, and it shows the rate per 1,000 discharges. And what you can see, drug number 1 is gentamicin, ranked number 1, and 822 out of 1,000 discharges get exposed to this medication. So virtually all newborn babies in the NICU get exposed to the medication. And this is a slide really showing the top 15. So gentamicin is one, ampicillin, etc., etc. You can read it yourself in the slides. And I think it's important to realize that of the fact that so many medications are used, we don't know that much about them yet. So this slide shows the determinants of drug response in newborn babies. The most important factor always is growth and development, as you can see in the upper part. But of course, normal newborn babies are at home with their parents and grandparents. When you're in the hospital, you have a disease that also will influence the growth and normal development. So these factors play a role, and in addition to that, the environment plays a role, and genetics plays a role, and I will all mention that later on in my presentation. Pharmacology means what happens when a drug goes into the human body: absorption, distribution, metabolism, excretion, and also, of course, why do you give a drug to a patient? What is the effect? And the majority of my presentation will talk about what the body is doing to get rid of the medication. So the challenge of neonatal clinical pharmacology is actually trying to find the sources of variability. There are two players. On the left part of the slide, ontogeny or development. On the right side of the slide, pharmacogenetics. In other words, what have your parents given you to metabolize medications? And clearly both factors play a big role in variability. There's a critical role of pharmacokinetics in pharmacotherapy. The combination of absorption, distribution, metabolism and elimination will dictate the exposure to the medication, and that will dictate the dose you're going to prescribe to your patients. So all these factors you need to know before you know how to appropriately use medications. Factors influencing oral drug absorption. This is a very busy slide. Don't worry, I'm not going to talk about all the issues here. I underlined gastric pH, and I underlined also gastric emptying time and intestinal drug transport. In addition to that, there's of course biliary function, splanchnic blood flow, intestinal drug metabolism, intestinal surface area, etc., etc. What I want you to take home for sure from this presentation is the fact that metabolism is not only the liver. Metabolism is also happening in the intestine and other parts of the human body. This slide shows you the developmental changes in gastric pH and related to drug absorption. As you can see on the y-axis, there's a percentage of adult activity. And on the x-axis, I'd like you to focus only on the first part of the slide, the HCl production, gastric acid production, from birth through adulthood. And you can see there's very little production when you're young, and slowly it increases and increases. And why is it important? Because the next slide shows you the alterations in intestinal drug absorption based on differences in gastric pH. On the y-axis, you see the penicillin concentration. On the x-axis, the time of the oral administration. And on top you can write here, can see here the orally administered penicillin. The black dots are preterm neonates, and what you can observe from this slide is clear that they are able very well to absorb penicillin when it's given orally to them. Even full-term neonates, the pink curve, is very well able to do so, but as soon as you get more than 2 weeks of age, it virtually stops. Showing that we need to know this, otherwise we're going to treat some patients with the wrong dose, they get an overdose, and other children perhaps an underdose. This is a slide showing you the developmental alterations in gastric emptying rate. It's about the 30-minute gastric retention. In other words, you feed patients and 30 minutes later you see how much of the feeding is still in their stomach. On the y-axis is the percentage of the meal, on the x-axis the postnatal age, in other words the age after being born. Let's focus only on the purple ones, the preterm infants. In the first 4 to 12 hours after being born, 60 to 70% of the meal is still in the stomach. A couple of hours later, it's only 40%, and then a couple of hours later, it's still around 40%. In other words, much more of the stomach contains the feeds in the beginning after being born than later on. This is clearly a developmental change. When we think about medications, and this is again a busy slide, but I will walk you through this one too. Looking at this medication, the Cisapride, it was studied in the network many years ago. That was sponsored by the NIH. We worked in 13 centers to do this. You can see post-conceptional age between 28 and 36 weeks, 17 children, 36 to 42 weeks, 13 children, and 42 to 54 weeks, 5 children. And I make the red for you to look at the Tmax. Tmax is the time that you reach your Cmax, so the maximal concentration of the medication. And what I showed you before, the fact that it was much more difficult to empty your stomach, you also can see in this slide. So when you give oral medication, when you're very young, it takes 5 hours to reach your maximum concentration. When you get a little bit older, 4.3 hours, and when you're a little bit more older, 2.2 hours. So there's clearly not only developmental change how you manage feedings, but also what happens when you give oral medications. Other factors influencing extra-oral drug absorption, again, busy slide, but as you can see in this slide again, I only underlined one, the barrier thickness, and I come back on that a little bit later. Of course, extra-oral medication is dependent on regional blood flow, temperature, hydration, local pH, and what I mean with extra-oral drug absorption is you give everything, for instance, you give it nasally, rectally, buccally, through the lungs, many different ways. The barrier thickness, I think, is important to realize. In this slide you see developmental changes. On the left part of the slide you see the skin of a baby born after 26 weeks, and I repeat, normal gestational age for term infants is around 40 weeks, so this baby is born at least 3 months early, of the first day after life. And what you can see here in this slide is clearly there's hardly any defense to the outside world. There's no stratum corneum, as you call that. So the same babies, you go to the middle part, 2 weeks later they have a beautiful developed stratum corneum, so they have a nice defense to everything that's put on their skin or comes from outside. The interesting part of the slide is when you're born term, in the first day of life, this part of the slide, you have the same kind of skin as the baby born 3 months early. So what happens when you're born prematurely, after 2 weeks your skin has been so much mature as if you're a term child. So something happens always after birth that makes your maturation much faster than when you stay in utero. So when you look at this slide, it shows you also the developmental changes in drug distribution. You see on the y-axis percentages, on the x-axis from birth to 40 years of age, and we see the differences in total body water in orange, extracellular water in red, and body fat in the dotted line. And what you can appreciate from this slide already is that the more young you are, the more you consist of water. The next slide will show you that much better. In orange, extracellular water, in green, intercellular water, in gray, protein, and in blue, fat. And as you can see clearly that the premature baby consists about 80–90% out of water. So sometimes we joke about these kind of little babies and say they're like little jellyfish. Whereas when you go to adults, they look more like calamaris when you look at the division about the different compartments. The importance is not to show you these differences just for you to remember, but also to think about when you use medications that needs to be dispersed or diluted in the extracellular water compartment, the orange part or the green part, then you need to know that probably you need to give more to premature babies than to adults. And that's counterintuitive, because we always think that children need less. And I want you to take home today also is that that's not also the case. Many times they need more, and then you have to be knowing very well how to do that. So then just an example, amikation administration. Amikation is one of the 4 frequently used aminoglycosides, an antibacterial agent. This is a study from Jean-Paul Langendries, a colleague of mine from Rocourt. He just retired. He published in 1993, so I like you to remember 1993, so more than 20 years ago. He published already, and I'd like you to focus on the first part of the slide, the volume of distribution. Think about the nice orange bars I showed you in the former slide. It shows here that if you're less than 28 weeks, the volume is 0.7 liter per kilogram. When you're 28 to 31, 0.66, etc., etc. When you term, 0.52. So it's clear that this medication reflects the orange bars. So the more premature you are, the larger is the space you're going to disperse the medication. Imagine that you need an appropriate peak level to kill the bacteria. Then you should also realize that you probably need to give more in the most premature babies than in the term infants. So what happened with that knowledge? Published in 1993. This slide shows you the Harriet Lane information. Harriet Lane is used by all residents, fellows and junior faculty in the US as a guidance how to use medications. I put on the part I only want to look at is the dose, milligrams per kilogram. Between brackets I put there the dosing advice in 2002, so almost 10 years after the publication. It was 2.5 to 3 milligrams per kilogram. Didn't matter whether you're premature, term, which age, so clearly not reflecting that the information we had already 10 years ago. And then finally in 2005 we changed. We doubled the dose per kilogram based on that information. So take home message from that is that we have a lot of knowledge, but we need also to have a time to educate people to use that knowledge to change their daily practice. It's very difficult. Physicians can be very stubborn. I'm one myself, so I can say that easy. difficult to change your habits, but for better care we have to work together to do that. Then let's go to drug biotransformation. There are different steps, as you can see here, phase 1 and phase 2. Phase 1 is cytochrome P450s and other enzymes, and phase 2 are the UGTs or NATs, like the N-acetyl transferases, sulfur transferases, all kind of steps. So why is it necessary? This is the reason why. Medications need to be metabolized. You need to get rid of them. And the first phase step is already to make a metabolite, but most of the time you can't get rid of it. So what happens after that in the phase 2 step, we make them in such a way that they can be excreted by the kidney. Remember, the first 2 years of human body development, the kidney is going to be the most important for any medication. So when you give morphine or midazolam or anything else, you need to realize that in the long run you need your kidneys to get rid of the metabolites. So when you have a perfect liver, a perfect intestine, but your kidneys are not doing well, be aware, because the metabolites can also have some very pharmacological action. So just some example about developmental changes of one of the enzymes. I'm not going to ask anybody to remember all these numbers, but this is, for instance, cytochrome 3A4, responsible for 50 to 60 medications we're using in daily practice. And this is a slide for 1997, so I want you also to remember that one. So, because the next slide is going to show you is 2008, so only 10 years later, and we know much more. But for 3A4, this slide shows you on the y-axis the percent again of the adult value, and on the x-axis I want you to focus only on the orange bars, the activity, from a fetus born before 30 weeks gestation, after 30 weeks gestation. Children only live for less than a day, less than a week, and it's all based on microsomal work. So babies passed away, livers were examined, and we were clear that this developmental pattern was there. Nowadays we know that there are different classes of development. It's Ron Heinz dedicated his whole career on deciphering this for us, and we have accepted that. So there are 3 different classes in this slide, class 1, 2 and 3. And what I'd like to remember is that class 1, for instance, contains cytochrome 3A7. That's a fetal enzyme, and we'll show you that later back on too. Class 2 is CYP2C19. I come back on CYP2C19 too today. And then class 3, by far the largest class, as you can see, not only having the cytochromes, the CYPs, as you can see here, but also phase 2 enzymes. So why are these different classes there? Here's a slide that will show you. On the y-axis again, the drug metabolizing enzymes. On the x-axis, the gestational age between 10 to 26 weeks, gestational age between 26 and 40 weeks, and then postnatal age between 0 and 6 months, and postnatal age between 6 months and 18 years of age. And when you look at class 1, you can see that in utero, when you're still in your mama's belly, there's much higher values of this enzyme than afterwards. When you look then at the class 2, there's some variation, but not a real relation between being before you're born or after being born. And then class 3, the large class, hardly any activity before you're born, and then it appears. Clearly, this system was not designed by our creator to do this drug metabolizing stuff. We're using it now, of course, to understand how we have to adapt our dosing for medications. The design of all these enzymes have to do with their normal development, endogenous steroids, get rid of teratogens, all these things more. I don't have time to talk about it today, but I think it's important that we realize that always, that these things we're knowing now, we adapt them to medications, but they were created for other issues. I mentioned cytochrome 3A7 to you earlier. That was in group 1, that's the fetal one. And what this slide shows you, there's a cytochrome 3A has different partners, 3A4, 3A7, 3A5, 3A43. Forget the numbers again. But what this slide shows you nicely is that before birth, there's a high activity of 3A7, and after being born, the 3A7 activity goes down, and in the meanwhile, the 3A4 activity takes over. We're still trying to understand why these changes are happening. It has to do with maturation, but it's very interesting that we are still not aware how that exactly works. Of course, I mentioned that all the studies we are doing are done in microsomes of livers of deceased children. The question is what you find in microsomes, can you translate it to real life, to real medicines in real patients? So this is a drug that we have been studying very well. It's not on the market anymore. Cisapride was only licensed for nocturnal dyspepsia in adult patients, and a lot of these patients got cardiovascular complications, QT prolongation and rhythm disorders, so it was off the market. We use it a lot in newborn babies, it worked very well. But why I showed you today is to show that We need to work together to, when you use a medication, sit together with clinicians, geneticists, pharmacologists, pharmacists, to see what you can learn from this medication. So this was a typical drug 3A4 substrate, so dependent on metabolism on 3A4. What I showed you before, the in vitro work. So we studied this in the same network, and this slide I want you to show is the single dose kinetics of Cisapride in newborn babies and young infants. The slide I showed you before and I underlined for you the Tmax. And now I underline for you on purpose the bioavailability related to the clearance. In other words, the lower part shows the clearance of the drug is 0.45 when you're very young, 0.75 when you're a little bit older, and 0.85 when you're even more old, indicating that for this enzyme it seems to be that the work from Ron Hines and his group showing in liver enzymes or liver microsomes this development reflects real life. So let's go to the kidney. This is, I think, a beautiful way of showing that the right part of the slide shows you the development of how you make glomeruli. We don't think about it as adults, but when you're in utero and also even when you're born prematurely, this happens continuously. So what you can see in the light microscope, in the LM picture here, is so from here you go to these bodies here, and then you move around and you go to the comma bodies and the glomeruli. So exactly what you see on the picture there. Why do I show you this slide? Not to show you that I'm a pathologist, because I'm not. It's just showing that active glomerulogenesis is still going on when you take care of babies who are born before 34 or 35 weeks gestation. So when you think about the babies born after 24, 25 weeks, they're 10 weeks in the NICU and still going on the normal development. So we have to be very aware that we might interfere very much with that normal development, and we don't know exactly what it might have for long-term consequences. What do we know? Normal maturation of renal function, what you can see here. You see the changes from the first days of life to 12 years of age, from kidney length, glomerular filtration rate, the renal plasma flow in yellow, and it shows you really that there are differences, but I think there's much more detail nowadays. And this is a slide showing you that in newborn babies, on the y-axis here, you see the glomerular filtration rate, in other words, the power of the kidneys to clear medications. And what I want you to focus on is the green bars this time, the term infants. They have a clearing capacity of 30 in the first 2 days of life. When you look a week later, it's almost 50. When you look again a week later, it's almost 70. Indicating that newborn babies, defined as children in the first 28 days of life, rapidly develop during their stay in the NICU or stay at home. Why is this important? I mentioned earlier, renal function is the key. So when you look at this, and you, for instance, a baby is ill the first 2 days of life, and you dose a medication with dose X, and the baby gets ill 2 weeks later, and you would do the same dose X, clearly you would underdose the patient dramatically. What it also indicates is that children in the first days of life are much more prone for overdosing than the children after 2 weeks of life in the NICU. So this is very important for you all to remember. There's an example of work I did many years ago for my own PhD. Ceftazidime pharmacokinetics. Ceftazidime is an antibacterial agent used in many units, and what you can see on this slide, on the y-axis, total body clearance of ceftazidime, on the x-axis, gestational age in weeks, and all these children were studied on day 3 of life, so no changes in postnatal age. And what you clearly can see from this slide is when you're born after 26 weeks, your clearance is 20, when you're 30 weeks gestation it's 40, and for 34 it's 80. Even when you correct for changes in weight, there's clearly a clearing capacity increase throughout the first weeks of life. I mentioned before, Langendries, 1993, I'm sure you remember that one still, amikacin. He advised then to dose 15.5 to 20 milligrams per kilogram every 24 to 42 hours. Other studies were done with Catherine Sherwin, advised us to dose between 14 to 50 milligrams per kilogram every 24 to 36 hours. Neofax, used by all neonatologists across the world, had another advice, but all in the same ballpark. Then the British National Formularian for Children, developed in the UK, as you can see, has a different advice, and that's clearly not the right advice. So what we did then in 2012, and we published it recently, we looked at all the information available, and based on our analysis we came to the advice between 12 to 20 every 20 to 48 hours. So remember, 1993, Jean-Paul Langendries advised us to do dose what is written on this slide. 20 years later, we do the most advanced analysis and we come more or less with the same advice, showing that we are not easy translating our knowledge to clinical practice. We really have to do that better. And you in the room and you're listening to this presentation are the future. So I think we have to work on that together. So let's then go to another part of medications, propofol. Why I use this example is a study by Karel Allegaert, a neonatologist in Louvain, Belgium. Why I mentioned this slide, and I'll show it on you to make you aware that when you work in a hospital, whether it's a children's hospital or a department of pediatrics in a large university center, you have to be aware that new medications are coming into the hospital because they're used in adults. In this case, here's propofol. Propofol is used for procedures. I think many of you probably have a propofol gotten for endoscopies or for procedures. The other thing what you can see here then is when you give it to a newborn baby, on the y-axis propofol concentration, on the x-axis in minutes the time, but realize 600 minutes is 10 hours. So when you give one dose, and I'd like you to focus on the upper part of the slide, when you're less than 27 weeks gestation, you're very young, in the first 10 days of life, after one dose you keep the drug on board for hours, perhaps for days. So when you don't realize this is a potentially very dangerous medication in the wrong hands. So then you go to the lower part of the slide. There are actually two lines. I'm trying to, here it is. There are two lines here. The same babies here in the first 10 days of life are maturing because after 10 days of life they're clearing it better, but still stays on board a long time. But also don't think this is only for preterm infants, because the same line shows term, so totally normal full-term babies in the first 10 days of life having also a big issue getting rid of this medication. In other words, we need to do the studies in newborn babies, otherwise we're going to overdose them and sometimes underdose them. Tip of the iceberg, because there's a lot of things we have to learn still. I talked today only about drug metabolizing enzymes. We know something about the development. We're trying to see what is done in liver microsomes is in real life also correct. But what we need to realize sometimes is that also other drugs come on the market that show something completely different. So I want you to go home today, not by thinking that we always need less in newborn or children. So this slide shows you the impact of age on linezolid pharmacokinetics. Linezolid is an antibacterial agent used against bacteria who are vancomycin resistant. In other words, your patients are trying to die from an infection because of vancomycin resistance, MRSA, and then this drug is going to be used. Clearly you need to know how to use it. And this slide will show you that if we wouldn't have done the study in the same network I mentioned earlier, we would have done completely wrong. I will underline the clearance of the medication. Clearance means how quick you get rid of the medication. And in adults, in this case, it's 0.1 liter per hour per kilogram, in children 0.3, and in young infants 0.52, showing that children and infants are clearing the drug much faster than you and I. So what means that if you don't know this, and you would give more or less the same doses in adults, you would undertreat the children and infants. So what would happen in clinical practice? The children and infants would die. And we would say this drug doesn't work in children and infants. It was only dependent on how much you give to this patient. So they deserve to be studied, and that's something we have to do together. I give you some more detail about this medication. You see here, on the y-axis the clearance again, on the x-axis the post-conceptional age, and there are 4 groups, and it's a quite busy slide, but I will talk you through this one. Open circles are preterm infants in the first week of life. Open triangles are the term infants in the first week of life. And then the closed circles and closed triangles are the same infants after the first 7 to 10 days of life. So what does it mean? This slide shows you the postnatal age on the x-axis. On the y-axis the clearance. So for this particular drug, it seems to be that if you preterm, so 23, 24 weeks, or term, you have some lower clearing capacity in the first week of life. But it doesn't matter after that how much you or how many weeks you were. After a week or 10 days, you have the same clearing capacity. We would have never predicted it with any knowledge we had. So without this study, we would have been completely using this medication wrongly. So to summarize my first part of the presentation, I think it's very important to realize that developmental alterations are very relevant for pediatric clinical pharmacology. I showed you differences in extravascular absorption rate and extent. I showed you altered body composition that influences distribution. Think about the amikacin. The ontogeny, the developmental changes in drug metabolizing enzymes. and also the importance and the impact of the development of renal function. Then let's go to one of the other factors. I don't have time for all the factors, but genetics, we have to. We are already more than 10 years now in the post-genome era, and as pediatricians, we can't put our head in the sand. So what is pharmacogenetics? Already in 1957, so 58 years ago, a German called Friedrich Vögel defined the pharmacogenetics by study of the role of genetics in drug response. And despite 58 years ago, I think it's still a very, very useful definition. So I show this slide for two purposes. Also for the young people who listen to this presentation. Don't stop thinking that before 1990 or 1980, not important things were published. Sometimes look in old literature and many, many worthwhile things are there hidden that you can use for your current research. So then let's go to a practical example. I think that always stays much better in our minds than just talking about the principles. So this is a case report published in the Lancet almost 10 years ago now, called Pharmacogenetics of morphine poisoning in a breastfed neonate of a codeine prescribed mother. The study was full-term healthy male infant. Both parents are physicians and they saw a physician every day, being nervous with their first child. On day 7 after birth, intermittent periods of difficulty in breastfeeding, that can mean everything, that can mean nothing. And day 11, the baby had regained his birth weight. Then most of the time pediatricians are happy. You lose all weight after birth and then you try to get back to normal weight between 10 and 14 days. But day 12, a grey skin and milk intake had fallen. That's an ominous sign. And the day after, the baby was found dead. So there was autopsy done because people didn't understand why it was happening. No abnormalities were found. The coroner was very active, so he tested for all kinds of medications and he found very high levels of morphine. So the question was, did the parents administer morphine to the child, and that resulted in the death of the child? So a few years ago we wouldn't have an answer, but now we have. I will show you the answer. So this is on the right side, there's a study published in 1998 by Germans showing that if you are a poor metabolizer based on your genetics of codeine or an extensive metabolizer, they got 170 milligrams of codeine orally, and the poor metabolizer are the white dots in the slide. You see, they hardly make any morphine. That's written on the y-axis. When you're normal, like most of you are, extensive metabolizer, you make a lot of morphine out of that dose of codeine. So when you think about the slide on the left side, codeine is metabolized by 2D6, and one of the brothers and sisters of 3A4, is converted to morphine, and then morphine goes to the blood-brain barrier to, of course, to give pain relief. So the question, of course, is what happened? Now the mother got medication because of a nasty procedure during the delivery. She got codeine and paracetamol prescribed by the Canadian physicians. I don't talk today about the morphine that was stored in the milk, but was the most important part of this slide is the lower part. Nowadays we can do genotyping, and this mother was genotyped and was shown to have a gene duplication. In other words, she was not the person who made normal morphine out of this codeine, but she made a tremendous amount of morphine out of this codeine, giving it to her child through her breastfeeding, and that way the baby was seized. And so this finding led to a black box warning for the FDA that you should not use codeine anymore in nursing mothers. And of course that's a wonderful sign not to do it, but then you have to find other solutions. And again, I can't talk about it today, but we really have to sit together to find best solutions for mothers. So we know more. So this is this CYP2D6, and this is a busy slide. A lot of Europeans have been working hard on this. I mentioned it already. You have the extensive metabolizers. The case is on the left part, the ultimate extensive metabolizers, and then we have also poor metabolizers on the right side in orange. And I put in this slide also Caucasians, because we have to realize we work with people with Caucasian background, African American background, Asian background, many different backgrounds, and they have all different ways of metabolizing medications. So it's so important again to work together, because sometimes we are all unable to do it alone. Another cytochrome I promised to talk about today is cytochrome 2C19, because that's a very interesting thing to share with you, because Omeprazole, the proton pump inhibitors, many people are using it, and even in children it's used a lot. And this slide was published in 2000. Remember again the year. On the y-axis you see the mean intergastric pH, so the value of the pH in the stomach. On the x-axis the area under the curve of omeprazole, that's the amount of omeprazole you can measure in the serum after a single dose of 20 milligram. There are three different groups here. The word functional alleles is in the middle of the slide. What does it mean? It means that you get from both your parents the capacity to metabolize omeprazole. Of course that's not the case, but they give you normal 2C19 capacity. These are the green patients. So after the normal one dose, they have not much area under the curve because you metabolize very fast, and they don't see a change in gastric pH. So these patients will come back to you as a physician and will tell you it doesn't work. Then we look to the yellow dots. One allele, so your father or your mother gave you something to metabolize omeprazole, the other one didn't do it. And you see these people are in between. Then there are 6 patients who parents didn't give anything to metabolize omeprazole. What you can see in this slide is that these patients show after one dose already a dramatic change in intergastric pH. In other words, these patients will come back to you and say, this is a wonder medication for my dyspepsia. 2000, remember, because a lot of literature that is new, especially also with genetics, changed dramatically. So let's go back then also shortly to the ontogeny of 2C19. I mentioned it already, we had the data from Ron Heinz. This doctor works with him for many years, and what you can see in this busy slide is the 2C19 again. And what you can see in the left part of the slide is the gestational age in weeks between 6 and 38. There's some activity going on, not much. Then we see postnatal age in months. There's a clearly increase in 2C19 activity. And then of course the years after it stabilizes. But what you also can see from this slide is that there's a huge variation in activity irrespective of your genetic background. That's the way it is. Then what we also need to realize in pediatrics is on the one hand you want to look at developmental changes of enzymes. But on the other hand you have to realize there are genetic differences that are very clear in adults but not that clear in children. And this slide depicts that very well. And again on the y-axis you see the clearance of the medication. On the x-axis, on the left part, the postmenstrual age, and on the right part, the postnatal age. Let's go to the left part first. The two red-lined patients are clearly there, not that we knew them already, but I circled them because when you go to the right side, when you give enough time for genetics to kick in, you can see that one of these patients is beautiful on the normal line, but the other patient is clearly far below. So what you need to realize is that we have to learn still at what moment in development your genetic background is taking control. And for 2C19 we know a little bit, but for 2D6 for instance we know after 2 weeks already. Prematures born 2 weeks later, we can already see which patients have a different background. That's important because they will handle medications differently. They have different effects and different side effects. That will make it a little bit difficult at the end of my presentation for you all, but this is I think important. Again showing that it needs to be teamwork. Nobody knows this alone. So this is drug X. Lack of association between 2C19 activity score and the elimination rate constant. So what you see on this slide is on the bottom the activity score. What is an activity score? We do genotyping nowadays and it gives you certain information. But what the most important thing is in clinical practice is not the genotype, of course it's your phenotype. So what we try to do now is to link the genotype with a phenotype. And for instance in this slide when you look on the bottom part, when you have a star 17 allele, no, star 1 is normal, star 17 is a mutation, then normally you're much more quick in clearing this medication. So the weird part of this medication is because it's one of the proton pump inhibitors, we don't see that impact. Why is it? We don't know. Then we have drug Y. Here we see perfect what we were thinking. This is star 17 again, higher clearance than the patients who don't have that. And I think it's so important to realize that why is this? And the reason is this. We need to know how these medications are metabolized. So when you look at omeprazole, it's dependent on 2C19 and 3A4. So when something happens with 2C19, the 3A4 will take over. But when you go to pantoprazole on the right side, it's primarily dependent on 2C19. So when you do something there, it has a big impact. Again, this shows that you need people with knowledge about genetics, clinicians who use the medications, pharmacy who know much more about formulations and other things of medications than medical doctors do, and pharmacologists. So altogether we can really improve the situation not only in adults but also in pediatrics. So my conclusions are that prescribing of drugs in pediatric patients deals with the impact of growth and development on pharmacokinetics and pharmacodynamics of these medications. It also is dependent on issues related to appropriate formulations, finding the right child-friendly formulation, get medications in children is a very challenging topic. Optimal design of studies, at least invasive as possible. Optimal analysis using population pharmacokinetics for optimal sampling, optimal results. And finally, of course, it's necessary to link developmental pharmacokinetics and dynamics with pharmacogenetics to optimize the safe and effective use of medicines in newborns, infants, children and adolescents. Thank you very much.